First of all, I'd like to welcome everyone for coming this evening. We are a group of medical professionals and interested citizens to shed some light on some important topics. This is our third year, and we tend to have excellent attendance, and the speakers I think you'll find dynamic and bringing some interesting data for you to contemplate. First off, this is a scientific conference. It's a medical conference. We're going to be presenting some scientific data and important topics, as I said, to stimulate some thought. Why are we here? It's really to provide some balance to the education and what you might get through standard channels. One of the stimulants for me doing this is when there was a talk on abortion locally, continuing medical education, and they asserted that abortion is safer than a colonoscopy. To me, it's like, wait a minute. And then gender dysphoria, which was one of our first talks 2 years ago, the same kind of thing. And we had a biased presentation, tried to bring in another speaker to present the other side of it, and that was canceled. And that's, as a physician, scientist, also a conservative Christian, I'll admit my bias, I thought, wait a minute, there is another side to this debate. And I thought it important that we bring that to the community. As far as our goal is to pull aside the veil of cancel culture to allow open discussion on important topics. And we are open to everyone. I'm not just looking for conservatives to attend. The idea would be to have everyone, and let's have a discussion. Let's look at the data, let's have a discussion. My disclaimer, I represent no entity of which I'm affiliated, and any ideas or opinions presented today are either my own or that of the speakers. So that's important to realize. Who am I? I'm board certified in internal medicine, pediatrics, and sleep medicine. I have a private practice, so I went kind of counter trend. I went from employed practice to independent practice. And probably one of the best decisions I've made as far as peace of mind, independence, not necessarily the best financial decision, but again, it's not all about the money. I do want to give a quote here. I was reading about this book called The American Bloods, about a family dynasty in the early founding of this country in Massachusetts. But Ralph Waldo Emerson, who interviewed one of the Minutemen, he had said, "It is easy in the world to live after the world's opinion. It is easy in solitude to live after our own. But the great man or woman is he or she who in the midst of the crowd keep and perfect sweetness, the independence of solitude." So in other words, they bring their thoughts into the public sphere with a courage that many don't possess. And these speakers tonight, I'm grateful for, because I think they represent just such individuals. So it was a very eventful year. We had unfortunate assassination of Charlie Kirk, having to have a conversation, and certain individuals didn't want to hear it. Thinking about last year's topics, the Hippocratic Oath, Dr. Nesbitt did an excellent talk last year, and unfortunately we see the spread of euthanasia. New York State just passed a law, New Jersey, Maryland, so we're surrounded. So I see a battle coming in PA. When? Time will tell. Excuse me. And then the abortion pill, that's unfortunately also going the other way, where we're seeing mail order, very little screening, and who gets it. The use has unfortunately gone up substantially. So I'm going to touch base when I introduce speakers on the other topics we've discussed in the past. As far as the logistics of this event, as you all know, this is free. I do ask that you consider donations to Expectations Women's Center, and they'll have a table in the back. The refreshments will be during intermission, and I want to thank my wife, Julianne, and who helped organize it this year. Kurt Fink made salsa, a gallon of it for people to have. And then Marietta Legarski is out helping, and others who I don't name, please don't take insult, but thank you very much. We have display tables, ACPs, advocates protecting children are in the back. Jeff's one of our speakers, Neurofaith, his books are in the back as well, and he'll tell you how you can acquire those. And parking validation, if the gate wasn't up, you may need to get a ticket that's available where you checked in, so your parking is free. The agenda, we're going to have a speaker for 40 minutes, 10-minute break, speaker for 40 minutes, and then question and answer session at the end. Other thank yous, Teresa Bertucci, who helps organize this for the Trade and Transit Center, and Dwayne Van Fleet with Jack's Realty, one of our main sponsors. Okay, let's move on to our talks. There's a lot of you may be available with something called the success sequence. To me, that's one of the prime things. If we could teach our youngsters, the adolescents, young adults, this is a path toward success, happiness. Starts with education, followed by work, marriage, children, and a personal faith, commitment, kind of like a moral code to live by. If you follow that sequence, 97% avoid poverty. Again, huge figure. Then there's also something called I learned last year I needed moisture here. Okay, the Human Flourishing Program, also similar things, stable marriage, participating in religious communities, stable job, social connections. And adolescence and childhood is a time of rapid growth, rapid change. Brain chemistry and a field called epigenetics can influence long-term what happens with that individual. And I know our speaker is going to touch into that. And one of the kind of mottos or something to focus on with ACPs is best for children. And that's one of my driving factors. Are we creating a culture and a society that truly is going to help our children to flourish? So, on to our first speaker. Dr. Michelle Cretella is a graduated medical school at University of Connecticut. She's a pediatrician. She did her internship and residency in Connecticut Children's Medical Center in Hartford. And it's funny how life passed cross, because I did my med-peds residency up in Springfield, Mass, just an hour or less to the north. And I drove through Hartford every time I went home to New Jersey or to my wife's family here in Pennsylvania. She practiced pediatrics 1999 to 2012, and then the calling of motherhood and raising 4 children, plus vital roles with American College of Pediatricians. She changed career track, became vice president, and then the first executive director of ACPEDS. I actually served on the board with her and the executive committee, so we had a lot of fruitful time together in discussions. She's now chair of the Adolescent Committee. In 2016, she came out with the paper, Gender Dysphoria in Children and Suppression of Debate. And unfortunately, we have seen that, and it goes on to this day. Suppression of that kind of balance that the literature would say, let's put a break on this, let's re-examine this. And unfortunately, in our country, it's become political. And in organized medicine, same thing. And we see that 27 states have put bans on it, and unfortunately, those are largely Republican. I think you told me 18 states have gone the other way, where they are now protecting hospitals and physicians who prescribe hormones or do the surgery. The American Society of Plastic Surgeons have stated with their members, do not perform those surgeries on kids. The data does not support it. And they even kind of said hormone therapy is also not well supported. There are studies that show worse psychological outcomes if they have it done. So it's definitely something we should not be following without a real open mind and open eye. So I would like to welcome my friend and colleague, Dr. Michelle Cretella.
Today we're going to be talking about what's traditionally referred to in mainstream media as abstinence education versus comprehensive sex ed. But what I would like, the proper term for abstinence ed is really sexual risk avoidance education. Because when folks hear abstinence ed, they think, oh, you're just standing up and saying, just say no. But as we're going to learn through the evening, it is much more than that. We are also going to take a critical look at comprehensive sex education and what that means. And we'll have to answer the question, is comprehensive sex education truly comprehensive, when in fact it is really focused on the secondary public health principle of sexual risk reduction. So, is teen sex a bad thing? That's really the first question we need to answer. What's so bad about teen sex? Isn't, human sexuality a natural biological function, just like breathing and eating, etc.? Well, we have very good studies and data to indicate that not only do we need to be concerned about teen pregnancy and sexually transmitted diseases, but early sexual debut, having sexual activity during the teen years, is increased with a higher likelihood of experiencing dating violence, as well as a threefold increase in depression and even suicidal thoughts. So all by itself, teen sexual activity can lead to this. And the hypothesis, the theory behind it, is because sexual activity is about the two B's, babies and bonding. And biochemically, especially in our girls, with sexual activity, the brain is flooded with oxytocin, the bonding hormone. Not just your the dopamine flooding, that's your that's in your addiction center of the brain, the reward, that's activated as well. But in the girls, that oxytocin, particularly with your first sexual experience, extremely strong, and that imprints on the mind. There's some oxytocin for the males as well, but in males, it seems that vasopressin is the neurohormone that's perhaps more prominent than the oxytocin. And vasopressin is associated with this this male possessiveness, bonding and possessiveness. Now, each time there's a breakup, that is what predisposes to the depression, especially in females, but also in the males. And so the more sexual partners you have, the more times you're triggering this bonding and breaking, the more or the greater the cycle of depression enters in. And the more difficult it becomes to have a long-term lasting relationship down the line. And this is why we see in studies with cohabiting couples, you've had previous sexual partners and you cohabit before marriage, those unions are more likely to end in divorce versus a couple who comes together to not sexually experienced, faithful, monogamous, married, in marriage, they have a greater likelihood of success long-term in a relationship. It's interesting on the teen pregnancy front, the CDC reports that teen pregnancies are on the decline, and what I found interesting is that the CDC attributes it to only two factors: the use of long-term acting contraceptives and more abstinence. They do not take into the equation, they don't take into the fact that emergency, EC is for emergency contraception, is over the counter, your Plan Bs, which can be purchased by boyfriends, by I mean, it's not like they card you, and the mail order abortion pills now. If you subscribe to Facebook, if you're on Facebook, you can look for Dr. Christina Francis. She is the CEO of the American Association of Pro-Life OBGYNs. And she has posted a very short video in which she walks her audience through a mail order abortion website and demonstrates that it is very easy for minor girls or an abusive partner, a sexual predator, et cetera, to just go through and order and obtain abortion pills. And she outlines why this is extremely dangerous for women's health. Of note, with the sexually transmitted infections, our young people between the ages of 15 and 24 only make up 25% of the sexually active population, but they account for nearly half, 50% of new STIs every year. And within that population, well, there are some studies looking at men who have sex with men. Some studies look at the age range 15 to 24 who are having sex with men. Others define it as age 13 to 35. You will see that they represent 0.2 to 3% of the population, and yet are responsible for between 18 to 30% of the new STIs. One of the reasons this is a factor is that, which does not get communicated to young people, is that even with condoms, anal intercourse is extremely high risk. One episode of receptive anal intercourse is 20 times more likely to transmit HIV versus one episode of receptive vaginal sex. As my colleague, Dr. Miriam Grossman, likes to say, the rectum, the anus, is exit only. It is not made to receive. So it's very prone to tears and infections. It also explains why, since HPV is responsible for causing cancer, it explains why men who have sex with men have a higher incidence of anal HPV and anal cancers. So there are many, this teen sex is a high-risk behavior. So for decades, the argument has been, well, we're going into the classroom. We don't know. We know some of these kids are sexually active, and it's really difficult to stop having sex once you are sexually active. So we want to include everyone. We want to bring a message of health that's going to be fitting for everyone in the audience. And we want it to be age appropriate, values neutral, but sex positive, meaning we're not going to shame anyone. And you don't want to shame, that is true, and we'll hear a lot about that from Dr. Hansen. Anyone who works with young people or even adult patients, you don't want to shame your patient, but you do want them to be healthy. Comprehensive sex ed does state that abstinence is the only 100% way to prevent pregnancy and sexually transmitted infections. And then it does promote condoms and contraception, as well as consent. There's a big emphasis on mutual consent for sexual activity. And the programs, the CSE programs, are particularly those recommended by the CDC and Health and Human Services, are promoted as medically accurate and evidence-based. And as far as evidence-based, this dual protective effect is what proponents of CSE say is the advantage over sexual risk avoidance, meaning we're going to have a double effect. We're going to be beneficial for the students who are sexually active, and we're going to be able to maintain abstinence among those students who are sexually abstinent. But if this is, and it's pretty much ubiquitous in every public school in one way, shape, or form for the last 40 years. So if this is really the best way to go, how is it that compared to other industrialized nations, we still have one of the highest teen pregnancy rates? In our own nation, the STIs, particularly gonorrhea, chlamydia, and now even syphilis, are on the rise. And the reason we should be deeply concerned about chlamydia and gonorrhea is because they are one of the leading causes of pelvic inflammatory disease, or they are the cause of pelvic inflammatory disease in our young women, which is one of the leading causes of infertility. And the majority of young people who do become infected with gonorrhea or chlamydia can be silently infected. So these girls may not know that they have pelvic inflammatory disease, they never get treated, and they are left with scar tissue. And it won't be until down the road, they're married, they want to have children, now they will discover, I'm infertile. And then of course, since 2016, we have had just more of a, now the mental health crisis is not due solely to sexual activity, but there has been a skyrocketing increase in the number of young people confused about their sexual identity, their gender identity. So if comprehensive sex ed is the answer, why are all of these things still so high? So the only organization, this is a scientific organization, the Institute for Research and Evaluation, that independently cataloged the studies being used, studies rated by the CDC and HHS as the highest quality studies of comprehensive sex ed and the most effective programs. They found 60 studies that the CDC and HHS rated as high quality, and they reviewed those 60 studies, covered 40 programs, which are used across the nation. So the Institute for Research and Evaluation said, we're going to analyze these studies, but we're going to relabel them. We're going to say that we will define effective to mean this program produced a positive impact in the student population 1 year after taking it. So 1 year after the program is completed, did they establish that their program increased abstinence? Did they establish that their program reduced teen pregnancy? That's the question they're asking. So if the programs increased consistent condom use, that's a win. Did they decrease pregnancy, decrease STIs? Those are wins. They also wanted to look at these studies to identify if there were any programs that increased sexual activity, increased sexual partners, decreased condom use, et cetera. So they did this for the 40 comprehensive programs, and then they also did it, as we will see later on, for some sexual risk avoidance programs. Now, shockingly, using that standard of let's see if there's a positive outcome 1 year out is a very reasonable, I mean, this is a school program that you're running all year. They found 85% of the programs failed to produce a single positive outcome 1 year out. Only 3 programs, so only 20 of the 40 programs studied actually surveyed their students at 1 year. Half of those 40 programs only surveyed the students 3 months to 6 months out. But of the 20 programs that looked to see, have we made an impact on these students? Only 1 out of the 20 increased abstinence, and 2 out of the 20 increased a report of recent condom use, which the researchers really, that was a gift that they were giving to the CSE program, because it's only consistent condom use that is protective. Recent condom use, well, maybe I used the condoms this one time and then I went and had 40 more episodes of unprotected sex. So, but these researchers said, we're gonna give it to them. So 3 out of the 20 programs, so that's a 15% success rate, and that's generous. 0 programs evaluated the consistent condom use, and none of the programs were able to demonstrate that they impacted pregnancy rates, STI rates, or a dual benefit. Six of the 20 programs that followed students for a year, 6 of those programs demonstrated the students admitted to decreased condom use. The increase in sexual activity is that more students reported engaging in oral sex than previously had, increased number of sex partners, and there was also, for 6 of the programs, an increase in reported pregnancies in the community. Now, Ascend, my last slide has several websites. So if you want to take a picture of one slide, I recommend taking a picture of the last slide. We Ascend is an organization that promotes evidence-based sexual risk elimination or avoidance. And they were able to survey youth, high school youth, to find out what their impressions were. Nearly 1 in 4 teens said that their comprehensive sex ed program made them feel like teen sex is expected. And if they were abstinent, they were weird. And many of them commented that the comprehensive sex ed program made them feel more pressured to engage in sexual activity than their own romantic partner at the time. So why might that be? So I have been a consultant to the Massachusetts Family Institute, as well as the Rhode Island Family Institute. And they have done a lot of, they've gotten a number of these comprehensive sex ed programs, which are all approved by the Massachusetts Department of Elementary and High School Education. And I can tell you that all of these curricula are used across the nation. And we will review some of the contents in the next slides of Get Real, which is by Planned Parenthood, Make Proud Choices, Our Whole Lives, the 3 R's, and Family Life and Sexual Health. So Get Real by Planned Parenthood for 11-year-olds discusses getting a girl drunk so that the boyfriend can make out with her. And remember this scenario, the scenarios are being presented in a values-neutral way. introduces masturbation by an older brother, introduces another scenario where there's a sexually active sibling forcing the younger sibling to keep that a secret from the parents. And the goal here is to drive home condoms, contraception, and consent, the 3 C's. Otherwise, it's values neutral. Get Real by Planned Parenthood, 7th grade, so as young as 12. List of dating behaviors includes touching under partner's clothing to having various sexual behaviors. Explains what a dental dam is as a barrier and teaches that, well, if you're too embarrassed to go and purchase one, you can create your own out of saran wrap. Prevents a scenario where the boy wants to see how it feels to have sex without a condom. I can pull out before it's too late. In that last one, of course, the importance of condoms is stressed, not the option of abstinence, not the option of refusal skills. In the 8th grade, as young as 13, normalizes child sex, introduces the idea of multiple sexual partners. Again, no shame in multiple partners, and no dangers of multiple. Not that we are recommending you shame people with multiple partners, but factually, scientifically, hold up the optimal health model. Discuss how can teens obtain condoms, emergency contraception for free or little cost, and these can be obtained, confidentially. Parental permission or notification is not required. And more than just sex positivity, you have a right to sexual pleasure. It's Perfectly Normal is a book recommended by multiple comprehensive sex ed programs and especially Planned Parenthood, recommended for ages 10 to 15. It's a core text in one of the other programs we're going to look at. There are 67 nude illustrations demonstrating masturbation in children, adults having sex, etc. We don't have to dwell on this, but if you may or may not, if you're educators, you may be familiar with this. Our Whole Lives, for grades 4 through 6, divided into 10 workshops using the previous book, It's Only Normal, as the core, It's Perfectly Normal as the core text. Hey guys, now they don't even say boys and girls because that would be transphobic, but human beings are sexual from birth. And again, in a value neutral way, there is a section called When Would I? So students, consider, when might you want to watch pornography? And if you were here last year, I believe from Dr. Hansen, you learned multiple harms from pornography. It's incredibly addictive, thanks to our cell phones. Once you have a smartphone in a child's hand, pornography is one accidental click away, and it is extremely addictive. It's free, it's private, so highly accessible, highly addictive. And even though many young children are at first embarrassed, repulsed, traumatized, shocked by it, there is a dopamine release which triggers that addictive cycle. And if they've been introduced to masturbation, either accidentally or in a CSE program, combine the masturbation with the pornography, you've got a far harder addiction to break. And pornography use in and of itself is associated with depression, anxiety, suicidality. And most of these comprehensive sex ed programs also affirm gender fluidity. But what is very important for parents, and I would wager most educators already know, you cannot, although you can as a parent opt out your child from sex ed, you cannot opt out from the transgender ideology, because that is literally present in every public school classroom in terms of anti-bullying. And it's brought in, teachers have their own reading libraries in their own classroom. So in terms of preventing harassment and anti-bullying, that entire transgender ideology can be right there in math class, social studies, etc., not just sex ed. Grades 7 through 9, this Whole Lives teaches outer course, so any kind of sexual touch without penetration in the vagina, anus, or mouth. Can be, you could be showering, hey, you're on a date, you want to take it to the next level, why don't you take a shower together? Fantasies, role play. Our Whole Lives, again, going up to your high school level, asks students, how many sexual partners have you had in the last 30 days? Talk about assuming that everyone's engaged in sex. What kind of relationship, what kind of romantic relationship would you be willing, what level would you be willing to do, skinny dipping with your partner, or stimulating someone's nipples, watch an erotic movie. There's the porn again. Give oral sex. It does promote abortion. Encourages students to become sexual rights activists. Be a peer-to-peer sex educator. Be a peer sex educator. Making Proud Choices is essentially a how-to manual. Negotiate condom use. Obtain consent for sex. As if consent for sex is going to protect your heart, your mind, and your body. This recommends detailed condom demonstrations using penis models. Others recommend using bananas. They use videos to demonstrate animated characters acting out various sex acts. Sample scenario in Making Proud Choices. Your parents are out late. Your boyfriend or girlfriend comes over hoping to have sex with you. Hey, I don't have a condom. Those things are gross. I can't even feel you. It just doesn't feel as good. Well, that's not true. I can show you how. It can still feel good. I'll show you how. Again, where's abstinence as even a possibility? The 3 hours by Advocates for Youth, not to be confused with Advocates Protecting Children in the back. Classic gender fluidity lesson. It's important to remember someone can have a penis even if they don't identify as a boy, or a vulva even if they don't identify as a girl. Normalizing pornography once again. Malik watches porn because he's nervous, he doesn't know what to do. And sadly, pornography has become the number one place, the number one go-to for kids for their sex education. So yes, what kind of sex education do we have in school is important, but it's not the only, the most important place we need to be educating our children is before they get a smartphone in their hands. The home is still the most important place, the primary place for all education. A video about this is almost unbelievable. A video about sexting for this rights, respect, and responsibility is shown. It's a video from YouTube, and the host says that if both parties consent to it, sexting is just, it's just normal sexual behavior. It's illegal. It's actually considered child pornography. Family life and sexual health is another. It originated in the state of Washington and Oregon, the public health departments there. and again, is very much focused on how to have pleasurable sex, where and how can you get your condoms and contraception, refers to Planned Parenthood. I had a mother, I can't swear that the latest edition says this, but in 2016, I had a mother who was a physician email me at the American College of Pediatricians, and she sent a photo of the workbook statement. It said, abstinence includes having a history of oral sex and anal sex. This program literally redefined sexual abstinence as including sexual activity that can give you AIDS, HIV, and AIDS. And yet, the CDC and HHS, under multiple presidents, include this in your teen pregnancy prevention program as an evidence-based program. Transgender ideology, this is another common book recommended for in the classrooms, and they are normalizing this young person. So the author interviews 6 youth who identify as trans, and one of the youths interviewed in this book states, from age 6 up, basically, he used to perform oral sex on other boys in the neighborhood. We were young, but that's what we did. Presented as normal and healthy. The gender unicorn, genderbread person, I'm gonna have to get moving. I can, in this slide, I could speak on for an entire hour, but suffice it to say that there are a significant number of studies in the psychiatric literature across the world to indicate that social contagion, traumas, and mental illness and neurologic difference like autism, ADHD, leads to the trapped in the wrong body belief. Those are the issues that we are urging young people to get counseling for, because when these underlying issues are treated and when they are healed, the estrangement from their bodies goes away. That's what needs to be done, and this is what has been recommended in a number of European countries, as well as even Sweden and Denmark. And there are significant harms to the cross-sex hormones, the blockers, let alone the permanent loss of breasts or fertility with the surgeries. Where is comprehensive sex ed coming from? It's coming predominantly from the Sexuality Information and Education Council, which was ultimately founded by a medical director of Planned Parenthood in the 1960s, based on Alfred Kinsey, who was a sexologist whose research findings were compiled by, among others, 1 to 2 pedophiles. So suffice it to say, the SICUS guidelines are what all of these programs follow. Monica Klein is a former sex educator for Planned Parenthood, and as she has pointed out, it's the perfect, their type, this comprehensive sex ed is the perfect business plan for a lifelong partner, a lifelong customer. And she was taught specifically that parents are a barrier to service. STIs remain on the rise. About 1 in 4 sexually active teen girls have an STI, and the majority don't know it. More concerning is that the peer sex educators trained by Planned Parenthood and others are taught to teach their peers, hey, sexually transmitted infections, it's a part of life. It's totally normal. Don't freak out. It's nothing to worry about. So we need to conclude that this CSE, this risk reduction, is not the one-size-fits-all answer. That's why it is a secondary principle of public health. Another example would be your needle exchange programs for drug addicts. We provide sterilized needles just to drug addicts. We don't go into a classroom with, oh, well, some of the students are using and some of the students or adults aren't, and offer sterile needles and drugs to everybody. But that is what CSE, so-called, is doing. The majority of teens, and this is available on the CDC website, roughly 70%, 68% of all teenagers have not engaged in sexual activity, particularly if you're looking at your 9th graders. Why is this a problem? Because the brains of our adolescent students, the risk and judgment centers of the brain are the frontal cortex, which in the far right picture, they mature in this picture when they're blue. That's your judgment center. That can weigh, oh, if I'm getting a double message, gee, what does that really mean? No. Students under the age of 25 are more being influenced by the amygdala, which is our reward center, pleasure, impulsivity. So this is why our children and our teens need a very clear message. And even physicians on the other side, professionals on the other side, Dr. Doug Kirby, this was in 2012, he came out with this. He had to admit that the sexual risk reduction comprehensive sex ed wasn't working in a published research paper. And he said, yeah, you know, it might actually be easier to encourage kids to delay sexual debut. Just like we encourage them to delay or never smoke, never use illegal drugs, and don't drink and drive. I have given you the handout, which has a link so that you can go and read the thorough report from the Institute that looks at both the sexual risk avoidance. The bottom line is that despite significantly less funding, and there are far fewer sexual risk avoidance programs than CSE, they have a higher rate of success. 7 of the programs demonstrated increased abstinence at 1 year. There was only 1 of 16 programs. So it's not 100% success. You need to ensure that the sexual risk avoidance program you have is medically accurate, has the evidence behind them. The best programs had the studies, followed their students for a year, and demonstrated effectiveness. 9 of those studies, 9 of those programs also asked their students if they had, not only did you have any of you started to have oral sex or any of these behaviors, they even asked about condom use. So all 9 studies that surveyed condom use found that those who were already sexually active, if they were sexually active at the start of the abstinence program, they continued with their condom use. So it didn't harm the CSE programs or proponents say, if you're in there teaching kids to avoid sexual initiation, you're going to lose those who are sexually active and make things worse for them. This is the second handout that was available to you. I encourage you to take it home, and it's an excellent comparison of the differences between the two. And the biggest take-home message here is that sexual risk avoidance teaches our youth about the entire person. It's not just about using condoms, contraception, and getting consent. This is about doing what's best for you in the present and in the future for your mind, your heart, your soul, and your body, and your future partner. And some will argue, well, this excludes the LGBT community. Why would we want our students who are same-sex attracted to be held to a lower bar? Why would we treat them as second-class citizens? Why? Are they not equally deserving of having the best emotional and physical outcomes in their relationships? So that's the response to that supposed objection. The success sequence. So Institute for Family Studies, just as Russ said, graduate with at least a high school degree, get a full-time job, get married before having children. Faith even seals the deal higher. Even with just those three, 97% of youth who complete the sequence, even if they were raised in poverty, even if they had single mothers, regardless of what ethnic background, 97% of them will not be poor by their 30s. And this is the slide you can take a picture of because these are excellent websites for further information. The best thing we can do to build resilience in our youth, whether we are parents, grandparents, educators, health professionals, we have to educate ourselves and learn how to ask questions. Teaching youth and other adults by asking key questions is the best way to invite them to open their minds. Teachable moments at home. So defendyoungminds.com, hands down, the best website for educators, health professionals, and parents when it comes to protecting children from pornography. Advocates Protecting Children, please visit our table in the back, acpeds.org, pro-family, pro-family, pro-life, pediatric, the only one pro-life, pro-family pediatric organization in the world. WeAscend.org has, again, the best sexual risk avoidance programs, Institute for Research and Evaluation, and the Medical Institute for Sexual Health. Thank you very much.
Our next speaker will be talking on adolescent risk-taking and resiliency. We are pleased to welcome him back after last year's dynamic presentation. He said, the only way I'm coming back is if I get a lapel mic this year, because if you remember that handheld thing was going up and down, and anyway, I'm lucky he didn't hit me over the head last year with it, but we got him a lapel mic for this year. One of the key features he talked about last year was media use and how we've seen teen depression rise to 60% among the females and 38 or so percent among males, so a steady rise. If anybody's been following the news, you know there is now a lawsuit that was lost in New Mexico by Meta, but that was more to do with child trafficking, which unfortunately the platforms do not protect our teens well at all against predators. And they're out there, and parents, you have to be so, so careful. But just the social media and where they're getting their self-worth from has been very challenging. There was a case, Los Angeles, that just settled also against Meta and one of the other big companies. That was for $6 million. There was a lot of other psychological dynamics at play with that case. But again, I think we are seeing the importance of strong families to protect, guide our youth during this vulnerable time frame. So, Dr. Jeffrey Hansen, PhD, he got educated in psychology, University of California at Berkeley, master's and PhD, University of Arkansas in Fayetteville in clinical psychology. He did a fellowship through Madigan Army Medical Center, Tacoma, Washington, in pediatric psychology. He was assistant chief, then chief, director of pediatric psychology fellowship at Madigan, went into private practice, and actually is still practicing, though direct-to-consumer situation, I believe, right? And being in primary care and trying to keep the balance sheet even to a tad positive is becoming increasingly challenging in this big world of medicine. So Jeff, in a lot of degrees, is a maverick. He's got this NeuroFaith initiative, which I think is showing tremendous potential, and he's got 6 books out back, and he'll talk about how you can get those books. So, and I've come and really, over the past year, I think I can call Jeff my friend as well, and I welcome you back. Thank you.
So it is phenomenally fantastic to be here. I just want to thank you for bringing me back. And I really have 2 presentations to give tonight. So I'm going to actually chop it in half. And maybe next year, I don't know, what will it be? If it's not a pork chop, it'll be something. But I'd like to come back at some point. But so I had planned to do actually the second part of this presentation, what I did last year, because I didn't really have time to finish. And then Dr. Gombosi said, well, we're going to talk about resiliency. So I had to do a big segue to do something different, which is really good because there's going to be a book coming out of this. I'm going to dedicate to you. And this man does phenomenal work at pulling this conference together. And without you, I wouldn't be here. Michelle would not be here. So thank you very much for having us. To keep the lawyers off my back, I'll say I'm not giving you medical advice, all right? So this is the second time I've shown this slide, but it's a phenomenally great slide. Let's get technical here. What is an adolescent? A rapidly evolving life form caught between childhood and innocence and adult responsibility, powered by sarcasm, caffeine, and alarming amounts of sugar. Known for questioning everything except their own questionable decisions, they possess the unique ability to sleep till noon, stay awake till worrying about life till 2 a.m., proceed with humor, and headphones. And yes, actually, humor is a part of survival, isn't it? We have to be able to laugh a little bit. So, what's the teen brain? Let's get even more technical. A powerful emotional engine. We're going to get into the neuroscience of that. Michelle kind of touched on that a little bit. Under construction braking system, or simply all gas, no brakes. And that is the way God designed us. That is the way we are. And the sooner we understand that, the more we can reach teens and help them. Now, anybody that knows me, I love motorcycles. I love motorcycles. And actually, that's kind of through AI. And it's supposed to be our BMW R1250 RS, which is a really nice motorcycle. But anybody who rides motorcycles here? Rockin' A. So you know about target fixation, right? So in a motorcycle, and actually even in airplanes, many pilots died because of this. Many motorcyclists have died of this. When you fixate on a target, and that's a danger, you will go to that. You instinctively go to that. And so we have all these risks we're talking about. Michelle did a phenomenal job talking about the whole sexual risk area. So it might be drugs, self-harm, reckless driving, danger. If that's all we focus on, we're going to crash over the guardrail into that. And we're really here to talk about resilience. And so if you ride a motorcycle, you look away from the danger. You have to notice it. You have to be aware of it, but you have to look around the corner. Where do we want to go? Well, today we want to go to resilience. Look through the turn. Resilience trains us to focus on the path forward. So these are 2 books that actually the second book, Adolescent Depression, that's your fault. Because I had so much fun doing this talk, I put it in a book. So this book and the other books you can get for absolutely free. I don't monetize my website. If you just go to my website, and I'll have cards down there in the back, and it has my website. It's neurofaith.net, very easy to find. And if you go to the webpage, recently published books, or I think it's our book manuscripts for free, I'm sorry. You can get all these in either PDF or Word format. And if you feel you want to write in a paper or you want to steal something from the PDF or the Word, I don't care. Just go ahead and use it. I don't worry about things like that. So that's the website, and all the books are there. And there you go. So what are our objectives? Risk regulation resilience. And we want to understand adolescent risk-taking through the neurodevelopmental lens. We want to recognize why regulation must precede reasoning. That's part of the neurofaith model. And then we want to apply neurofaith bottom-up, top-down. Information's flowing all the time up and down. What do you think? Is it more bottom information up or top information down? Yes. Who says bottom information up is more or top information is more? So bottom up, more, raise hands. Top down, raise hands. So about half and half. It's actually 80% of information flow in the body is up, right? That's it. And then 20% is down. So what goes on in the body is massively important. We're going to talk about that. And then we want to integrate brain and heart in resilience building. I'd love to get into a discussion of the neurofaith model, but I'm only just to maybe just introduce that. I don't have time, I don't think, to get into it in detail. So we have a crisis in the making. These are a few slides that we saw last time. How many people were here last time? So about half, okay. So we have an epidemic in our country. Michelle touched on that. We have an epidemic of depression, suicide, etc. 1 in 5 teens are suffering from major depression. Major depression is no small thing. It's a big deal. Suicide is the second leading cause of death among individuals. So why is that? Now, we're not going to be able to go into detail all these. I'm going to skirt through them pretty rapidly. Jonathan Haidt's work on play-based childhood versus screen-based childhood, ideologically based dogma, Michelle touched on that. Pornography, she touched on that. Connected living, new point. Trauma will be new point. So look at this. Since 2010, 109% increase in suicide. That's scary. And incidentally, this slide deck, if you go to my website under Neurofaith Trainings, you can get the slide deck. So all the slides are for your consumption. 134% increase for females, for girls. For teens admitted to hospitals for non-fatal self-harm, I mean, that's staggering. Girls, 188%. So the crisis in mental health is affecting both males and females, but females far more. Boys, 48% increase. And look at this, anxiety is skyrocketing. And especially in the young kids, the old folks like me, we're just kind of chilling along pretty good. But the younger you are, the more anxious you are. Why is that? And then what is happening in terms of mental illness in undergraduates? Also, anxiety is more than depression. Shocking, isn't it? And people think that depression is a major conduit for suicide, and it is. What some people don't realize is anxiety is a major conduit for suicide. These kids get so activated and they get so HPA destroyed they can't settle, and they'll take themselves out. They'll start with self-injury and then they'll take themselves out just to get away from it. And the PISA scores, the program for international school assessment, these scores are given about every, I think, 3 years for 15-year-olds. Everybody, all the industrialized countries are just tanking. So our kids are doing less well. And Jonathan Haidt, who knows Jonathan Haidt? If you have kids and want to know about kids, I highly recommend his book. It's a phenomenally good book. He's also a very good speaker. But he postulates, and I agree, that we've switched out a play-based childhood for a screen-based childhood, and that has completely wrecked a generation of kids. And if we're honest with ourselves, it's kind of wrecking us, isn't it? So there's many wonderful benefits from media. There are also many perils. So look what happens in the adolescent brain, in this digital culture of ours. Kids need attunement and connection. They need 3D connection to connect and to develop. Screens are replacing real eye contact and empathy. The insula in many children's brains is less developed than it used to be. Identity is externalized. We need to have an internal sense of who we are. We're exporting to these other things, and the stuff we export it to is not healthy for us. Sleep and arousal. You're a sleep doc. You know that, don't you? Kids are not sleeping well. And then we have dopamine overload. We'll talk about that later. And emotional escape, numbing and avoidance of real emotions, and they're using that to placate. Look at this with your heart for a moment. The way it used to be and the way it is. Use my pointer, huh? Isn't that sad? The way it used to be and the way it is. And that's maybe a bit of an exaggeration, but who hasn't gone out to restaurants? And everybody's on media. We no longer experience the real thing. The other becomes an image for me, and I the image for the other. Heck of a way to relate, isn't it? Heck of a way for our children to develop in that world. And Johan Hari is one of my favorites. Anybody know Johan Hari? He's actually a British journalist, and he did a walkabout around the world to try to figure out what is causing so much increase in depression. And he came up with this model of disconnection. His book is one of the best books, and he's not a psychologist, he's not a therapist, but it's probably one of the best books on depression I've ever read. We have become massively, massively disconnected. Now, if we're not well connected with good things, we're going to connect with not so good things. That may be addictions about bonding. If you can't do it with people, you're going to do it with a substance. You can't do it with a substance. That also might be gambling, media, cocaine, cannabis, but you're going to bond to something because that's our nature. That's what we do as human beings. We connect. And sadly, we all know this. How many times, how many minutes have we all spent on our cell phones a day? I have to confess, I was checking a text before I spoke this evening. We're all guilty of it. And it's affecting us, it's affecting our children. Michelle talked nicely about victimhood culture. They talked about the whole issue of ideological capture and how that's infecting our children. I'll say briefly, anybody know Michel Foucault? Or Judith Butler from my alma mater at Berkeley? Or Gail Rubin? Well, they all think that it's a great idea to completely destroy normative development, normative family, normative sexuality, and anything that's abnormal is fine, and anything that's normal is bad. They've uprooted it, and it sounds paranoid, but there is an ideological movement to capture our children. And the pornography stuff that Michelle spoke so eloquently about, it's all about that. Judith Butler in particular at my school was advocating for sex with children, adults having sex with children. I kid you not. Michel Foucault, who died of AIDS, was having sex with adolescents knowingly, and he advocated for in France to have a law allowing, or actually a sex age issues with children abolished, so you could have children sex with anyone. So I just added this slide because I realized that I'm not going to go into trauma in any detail, but developmental trauma is massively a big setup for loss of resilience and all kinds of emotional issues with children. Does anybody know the difference between little t and big T trauma? So little t trauma is what we call developmental trauma. It's the stuff you pick up in childhood. Lack of connection from parents, lack of validation, a divorce, being beaten, abused, etc. All that develops into the child's inner core and gives them negative core beliefs about themselves. If we have time, we'll talk about that a little later. But it wires into the default mode network. And the default mode network is that part of the brain that allows us to do kind of things automatically. And if we didn't have it, we wouldn't be able to get through the day. So a lot of good things get wired into that default mode network, but also some bad things. So if you've had loads of trauma, you're going to get negative core beliefs about yourself, and that will take you out. I'm not worthy. I'm not valuable. I don't matter. That wires into your default mode network as a result of developmental trauma in particular, and will then infect every interaction you have, every prayer you say. It taints it. It's like wearing glasses with a certain tint. Everything that comes in, and then you will then, through your experience growing up, actually have a response to selection bias and just have you'll confirm those negative beliefs. And unless you address those things in therapy, people don't get well. They don't get well. So, trauma I'm not going to get into epigenetics, but it affects the way genes are read or not read. All kinds of issues with autoimmune disease, etc. Overloads the stress response, weakens emotional regulation, disrupts attachment and safety, taps into the fight, flight, or freeze. If we have time, we'll get into that a little bit later. And what we see clinically, emotion dysregulation, cognitive impairment, physical health problems, mental health issues, and impaired resilience. So trauma is a really, really big deal. And the types of therapies we often do, like CBT and DBT, don't get at that. So therapies have to go deeper. So what does this word resilience mean? Think of a spring. If a spring, you compress it, right? You let it go, that's resilience. But think of the two things. Compression means the system, the child, has to have some stress. And you bounce back from that. It's not just bouncing back, but it's being under pressure. So there needs to be some amount of stress for normal development. So what does the neuroscience say about risk-taking and resilience in teens? When resilience fails to develop, that's not innate. You don't just automatically get it. It's built through, focus on these words, attachment, co-regulation. That's the ability to regulate to some other person who's more subtle than you are. Co-regulation. It can go in a good way, and it can go in a bad way. When these are disrupted, resilience does not form as it needs to. So you're setting yourself up, the child's being set up for having all kinds of problems. Now, same root, different expression. Does anybody psychologists here, therapists here, use the CBCL? It's an old instrument. I've used it for decades. But it breaks things down to basically internalizing problems like depression, anxiety, externalizing problems like ODD, oppositional defiant disorder, acting out. So it's going to go one of two ways. Internalized, externalized. Same root, different expression. Now, nonetheless, the nervous system still demands regulation. And those of us who really work, if you work well with children, you'll understand the whole literature of regulation and what that means to be safe. What's Maslow's? Anybody know Maslow? Talk about all the needs. The first one is what? Safety. The first one is physical. The second one's safety. And then there's all these others built on it. So it's massively important. We need safety to develop. So the predictable acting out outcomes, sex, pornography, drugs and alcohol, we know these, right? Some of us did some of these, didn't we? Danger, thrill seeking, aggression and violence. These are not random behaviors. We all know we worry about our kids when they get that license, right? Because they get reckless, and we're going to talk a little bit later why that's so dangerous. However, newer, more dangerous forms of risk-taking are increasing in part due to this lack of resilience. What are they? We have this whole digital world. So too much digital exposure changes the neurosystem, but then we go to more digital behavior to resolve what we already have dysregulated. Does that make sense? You're chasing your tail. Dramatic rise in screen exposure, dopamine-seeking behaviors, and impulsivity. If you could do one thing for your child, keep them off, we call them smartphones. That's an incredible name, isn't it? Nothing smart about it. We should call them devil phones. I don't know what we should call them. It'd be a different name. But we should keep them out of hands of teens. If you can keep out of hands until 14, good for you. And I even advocate give them a smartphone, but make it dumb so they can fit in socially, and maybe allow them to text, but don't have much else, because it's just not good. Okay, so Michelle did a great introduction from my talk. She kind of hit on these issues that we have the reward system, which develops before the regulation system. You're going to see the same concept in about 4 or 5 different slides. So you're going to really get this, I hope. But you think about it. Adolescents aren't reckless because they don't care. They do care. We think they don't care, they care. They care. They're vulnerable because their reward system, those systems mature before their regulation systems. Really important to understand that. Because we start going to their prefrontal cortex and we're talking to that way too much and not understanding they're in their limbic system and we miss them. And there's this kind of communication. You just don't reach them and they feel so misunderstood and then they feel shamed and then they separate. So they have faster dopamine hits because we're changing their brains to fast-paced regulation, or fast-paced stimulation rather, constantly. And so their brains are looking qualitatively different than old fossil brains like me. Very, very different. Constant stimulation, less unstructured play, and you need structured play, you need risk. Risk is very important. Reduce attunement, remember digital in that earlier slide? Lack of attunement. You have to have that connection. Then you have increased social comparison, slower nervous system recovery. So our kids now are developing with not ever getting into, I shouldn't say ever, but way less access to that safe state. There's 3 basic states. I may not get to the slide later, so I'm going to say it now. One is activation. When you're under threat, you're going to activate up with more energy. Or you're going to shut down. This activation is called hypothalamic pituitary adrenal. Just think HPA and just think loads of cortisol. Or you're going to have this other system that's going to shut you down. We need to be in the safe zone. That's ventral vagus. I'll have a slide later to show that, hopefully. And that's what we need to be. Our kids are not getting in those states. They're growing up in too much of the defense states, and that gets wired in, and then as an adult you go to that way too much. If you have a combat soldier, 2 soldiers in the same battle, I've seen this so many times, and so they both have the same shock trauma. The buddy gets killed, gets blown to a million pieces. And then they both go to therapy. One does quite well in therapy, and one just tanks and gets nothing out of it. And one of the big discriminators is how much early developmental trauma they've had. Why? Because if you have this state that we grow up in, this defense state way too much, and we're not regulated to the safe zone, you'll go to that every time. So it's almost like the double whammy, right? And hopefully we'll get to the slide. I can show that to you later. So the new adolescent risk, yes, they are at risk, as Michelle said. They're massively at risk for sexual transmitted diseases and all the crazy stuff they're being taught. I mean, crazy stuff they're being taught at school. And those books are alarming. Those books that they get are alarming that she mentioned. So, but they're dating less. And they're less face-to-face interaction, less unsupervised social exploration, less tolerance for rejection and awkwardness. Safety is replacing development. They're trying to get to a safe because they're so racked with anxiety, they're not willing to take relational risks. Isn't that amazing? So they're moving from, now they still have plenty of acting out, don't get me wrong, but we're shifting from acting out, substance abuse, behavioral acting out, externalizing distress, to more of this, anxiety, depression, social withdrawal. That's the anxiety, depression is exactly what Jonathan Haidt talks about. So we have digital overuse, identity diffusion. Kids don't know. And adolescence and childhood is a part of kind of figuring out yourself out. And you're so confused. But they almost like can't find it at all. It's really, really painful to watch them. So we have this digital adolescence, low risk in getting out and taking risks, right? High stimulation, isolation. That's a setup. And in the real world development, you need to have experiences with rejection, embarrassment, vulnerability. How do you be assertive? You try assertive, it doesn't work. You try to initiate, it doesn't work. That trial and error builds resilience. But our kids, our teens, are not having the experience to build resilience. So they look very, very different. We have digital sex. We have sex and novelty, or novelty without vulnerability, control without mutuality, and arousal without attachment. So when you mess with porn, as so many adolescents, about 80 to 90%, what's the average age that kids start playing with porn, messing with porn? Average age of exposure is 8. Used to be 12, then it was 10, after that's going to be 5. I've had kids as young as 5 act out sexually. As age 5, I had an 11-year-old try to rape a 5-year-old. I had all kinds of cases like this. Oh my gosh, and when I started, because I've done this for 40 years, I never got these cases 30 years ago, ever. And now I get them often enough. Horrific acting out. So, you just need to experience kind of a play on the other slide, but fear of rejection, fear of exposure, fear of inadequacy, they're afraid to try these things, but you need these experiences. You need to overcome these fears. Does that mean I got 10 minutes? Oh my gosh. Okay. Really? We're going for 30 minutes? Oh my gosh. Okay. So, we learned bottom up. The limbic system wires in first. This is one of my favorite slides. I had a lot of fun with AI making this slide, but just focus on that. Our young people have this go system, right? That wires in first. Later then becomes the prefrontal cortex, planning, self-control, decision making. And if we over-talk, as I said earlier, to the prefrontal cortex, we lose them. So, let's skip that guy. Yeah, I think I'm going to go this guy. So as Dr. Michelle commented, the brain is myelinating, right? So the brain does two things from age 12 to 13 all the way up to 24. It's pruning out stuff it doesn't need. You have an overabundance of neurons, but the stuff you're using, as it sees neuronal flow over a circuit, it myelinates it and makes it rapid. And you're pruning from 200 billion neurons to about 100 to maybe 85 billion. Isn't that amazing? You're just whacking out. So the brain's going, you've got tons of extra stuff. You needed that to develop. Now we can get rid of it. Now let's start making your brain efficient. But this is a really great slide because it kind of says it all. If our kids are doing a lot of stupid, okay, the brain's going to go, those neurons are firing, the lot of stupid gets wired in. And if you're not doing the smart stuff, that gets, the brain's going, well, the math stuff and the executive functions you're not doing, it gets pruned out. So we want to be tracking with our teens, making sure they're getting exposure to the right things. Does that make sense? So, forcing a teen to open up in the wrong place. Now we're talking about treatment and what to do here. It's a few slides. I'm probably about down to 6 minutes. Time goes faster when you're up here, I'm just telling you. I've been up here for 10 minutes. It's like you're telling me it's 40. Anyway, so forcing a teen to open up the wrong way is like poking a bear and expecting a hug. You ain't going to get it. And, the 80-20 rule, I showed this last time. Listen 80, talk 20. Don't preach, don't lecture, don't dialogue, and just remember, teens have one superpower. Hypocrisy detection system. And it works perfectly on parents. So if you're not preaching what you're speaking, shut up. Duct tape. Take a look at your own behavior. And then also, we as parents, come on, we're anxious about our kids. Suck it up and try to just don't go there with them. And just put your fingers behind your back, cross your fingers, I'm just feeling really confident. When our children are scary is when they most need to hear from you, I believe in you. Ask my son Greg when he ran away at 12. I did this, son, you're going to be okay, I believe in you. I really had to stretch it, and I really had to try to be that. But he needed to hear that in that moment. They don't like us to be anxious. And this one statement, motivational interviewing, I'm not going to get a big discussion of it. But the one thing I want you to take away, if you can ever avoid, never say to your kid, I need to talk to you, we need to talk. Start with, son, would it be okay if we talked? I have some things I want to share. Would that be all right? Now, if they say no, you still win, because they know you respect them. Believe me, you'll be able to get back to it later. There are times, yes, you have to pull rank. But try to not pull rank. That's the one thing I want you to get out of motivational interviewing. By the way, it works great with spouses. It works great with spouses. So, a few ranty comments. I promised Dr. Russell I wouldn't rant too bad, but I got to rant a little bit because this is what I do. Pills don't build resilience. Behavior control does not heal shame. What is required for is transformational healing, transformational change. And so therefore, we go to meds way too much. Many physicians and frontline prescribers or providers are taught you got to go to an antidepressant first. Not saying, but I'm not against antidepressants. What I'm saying is, if you can, don't go to that first. If you take your child or a teen and they spend 15 minutes with your kid and they want to go antidepressant, I would run. I would run. Or at least I would ask them why. Or at least could I have a referral to a really good child psychologist or whatever therapist who can dig for some other things that might be going on. Please do that. Way too many teens on antidepressants and all kinds of medication. When we have over-prescribing, we have emotional blunting and numbness because antidepressants don't heal anything. There's no such thing as a serotonin hypothesis. It's been well-researched, meta-analytic studies, Joanna Moncrief and others. It does not exist. It does not fix anything. It does numb. And if you need someone to have numbed down feelings, that at times can save a life. So it's like, it does have its place. But it shouldn't be the first thing, but only rarely. It creates dependency and identity. I've had kids cry their brains out because I wouldn't refer them for meds, because they so wanted meds. And then when they stayed with me, they were happy they didn't get on meds because they got to the root problem. Abigail Schreier, one of my heroes, irreversible damage, right? Am I remembering that right? Yeah, we were talking about, she wrote this great book on contagion of gender identity, crazy stuff. But her second book is Avoid Bad Therapy. Vet your therapist. Find out where they are, where they went to school, what they believe. Will they talk to you as a parent? If they won't talk to you, I wouldn't see them. Yes, kids, and I don't know what the state laws are in Pennsylvania, but in Washington State, 13, you couldn't talk to the parents. That's crazy. I just didn't agree with it. I always got informed consent from my teen to talk to their parents, and it didn't violate HIPAA, but I did it all in the open. But you need to have parental access. Therapies pathologize normal pain. Bad therapies create symptom identities. They undermine parents. They reward rumination over resilience and ideology over psychology. My profession is a disaster right now because we're pushing ideology over, and that's a failure of informed consent. It's malpractice, but we are told to do that. Healing involves mind, body, and soul. Just a quick moment. Incremental therapies like DBT, CBT, as I mentioned earlier, are very good. But they won't lead to transformational change at all. Transformational change must heal at a much deeper level. And my model, which is basically taking two massively neuroscience-based approaches, helps deal with what's in the body, because trauma stores where? In the body, right? Vasobandical, in the body. And yet we have psychological defenses that help us deal with what's in the body. That's IFS, dealing with the parts. I'm going to show you one quick slide. And then through all of this, faith and spirituality. Now I'm an unapologetic Christian, But the research is clear that other faiths also are very helpful and also are very neuroprotective. So I'm not dogmatic that you've got to be a Christian, but if you have some faith, it's great. I work with Vikings, I work with all kinds of people of different faiths and had really good outcome. Spirituality is so neuroprotective. And when you go to my website and download that, you'll see all the massively neuroprotective things. So the one slide that I was kind of talking to earlier is this one. We need to have safety to grow to develop normally. All the media, all the sexual exposure stuff that our kids and the ideological capture takes kids out of safety, all the developmental trauma stuff, and they don't get enough of this. That's the vagus nerve. It's a beautiful nerve, isn't it, Dr. Russell? And when you are activated, you're running way too much cortisol. And that kills every organ in the body. Or will shut down that way. And the way that works, I know I'm just about out of time, but the autonomic nervous system has that sympathetic, that would be the red zone that we saw earlier. The parasympathetic divides into the ventral vagus. That's the more advanced part of that nerve, and the more primitive part is the dorsal vagus. So you'll shut down, you'll activate up, but we need the green zone. And that's where therapy has to be. That's where parenting has to be. That's where the schools should be. That's what they need to get this basis of what helps them to become resilient. And then we know that the heart has massive wisdom. And what I would say to parents, what I'd say to children, help them get out of their brain, get out of their thinking so much. That is of importance. If you have trauma in whatever, you've got to get back in your body, right? The Bible says the peace of God will keep your hearts and minds. Hearts first, then minds. 80-20. So it's this is very consistent with the Bible. And then, lastly, the IFS stuff just helps us deal with the defenses that we have, the cycle to deal with what's in the body. If we have too much pressure, that's the exiles, and all that trauma gets squished down. We'll have a defense either to overmanage it, right? Become too much of a doctor, working too many hours, too much of a psychologist. We're managing our stuff, aren't we, Dr. Russell? But then we have firefighters. If you can't contain it proactively, you'll act it out. That's where drug addiction, sexual acting out occur. And we need to be able to balance, deal with the pain so these systems can be balanced. Does that make sense? And then I know I'm out of time, so I'm going to go all the way down here. I gotta end. Motorcycle. Just gotta end there. So we want to see past the danger. We want to understand. That's our goal, to get to resilience. We go where we look. So resilience grows when adolescents experience secure attachment, emotion regulation, and meaning. Didn't talk a lot about that, but we need to be talking about values with our children, what we believe. We don't tell them what to believe, but we give an opportunity to accept what we as parents would like them to consider. It's strengthened through connection to people, purpose, nature, work, and faith. True healing integrates the brain and the heart, addressing trauma at its roots rather than managing symptoms. We can do this. We can do this. We go where we look, help them see past the danger, and around the turn towards resilience. So with that, I thank you very much. How do you do on the time? I run over a little bit? Okay, 3 minutes, all right.
Well done.
This is for any of the three of you. I'm a book lover. How does the loss of the reading culture tie to this? And does reading, as opposed to being on a screen, factor in as a healing mechanism at all amongst many things that you are recommending?
A hearty yes, absolutely. What we need to do is to get our kids, keep them off screens, reading books, and interacting with other kids outside. I'm very much keep it reasonable, but the free range kids with a reasonable amount of supervision, but they need to be outside and active. And when they are inside, whether it's board games, reading books, no screens. But yes, reading books, it's tactile. You've got to integrate as many of the senses as possible for optimal learning and development.
As a sleep specialist,
Yes, avoid
cell
screen.
phones should not be in the bedroom of teenagers. There should be a charging station in the kitchen. Don't let them sleep with it. We've seen the amount of sleep teenagers get go down substantially. And we also know attention deficit disorder increases significantly when there's excess cell phone use, because they're flipping from one thing to another rapidly. They're not spending time in a book. So reading is helpful when it comes to sleep, and I think it's helpful for focus and development.
So there's a lot of research coming out on the difference between reading on a screen and reading a book. And when you read on a screen, of course, what you're saying is it activates the HPA system. You have adrenaline cortisol cranking through, and just not good. It messes up melatonin. But when you read a book, the learning is deeper, way deeper. Retention's better. When we read a book, we actually peg without realizing it where it was in that book. Think about the last book you read that you really liked. You can see, yeah, it was kind of like 2/3 of the way in the book. I remember it was halfway down the page. That type of processing is way deeper. That 3D experience is way deeper than the 2D. So when you read on a screen, you're activating, but you're not getting the same depth of reading as well. And reading a good book is tremendously ventral vagus, right? It's tremendously calming if you like the book, right?
Just one other comment. You know, when we see adolescent depression, anxiety rising substantially, we heard a number of reasons. One other big reason is the amount of sleep an adolescent gets on average is an hour less than it was 15, 20 years ago. So it's definitely, and we know sleep is so important for neurodevelopment. So, another question, anyone? Yes?
So when you're talking about resiliency and the brain and the way it processes things, how do you look at things, and I'm assuming most of what you're discussing is in a neurotypical development and a neurotypical brain. How does that look for those who have neurodivergent or neurodevelopmental disabilities such as ADHD and autism?
So the question she's asking is, the normal brain processes things a certain way. How about the brain that it has more ADHD or some other neurologic deficit?
Well, I would say you're adding kind of insult on insult. If you're like too much screens on a neurotypical brain, is that what you're saying?
So like you're talking about resiliency and how I'm assuming most of that information was based off of a neurotypical brain or like somebody who doesn't have some sort of neurodevelopmental disability, such as ADHD or autism. How does having that neurodevelopmental disability affect the information that you're talking about with resiliency and those kinds of things?
I think that's a great question. I don't think you can answer it here. I think it's such a broad, wonderful, beautiful question that deserves a lot of attention. But if you have a person who, say, has like an autism spectrum kind of thing, and they're already having trouble connecting, you overstimulate them with stimuli, their autism, of course, will get worse. There's a whole condition called, by many, virtual autism. Kind of helps create it or activates a version of that. But I would say that it would depend on the type of neurotypicality, because this is a massively broad category. And if you have someone who has, and at least in my practice, when I'm dealing with someone who has autism or a learning disability, you have to take this, because then you have to adapt it to a level where their resources can receive it. Monda Delahook's work, if you ever read her work, she's very clear on knowing where the developmental markers are for that child or that teen. and you tailor the program. So this would not be one size necessarily fits all. It's a great question. You have to take elements of it and go, okay, what is specific about this child? What's specific about how their brain's working, right? And you tailor it to them. So yes, point well taken. This is a generic, and I think sometimes we don't respect enough of the atypical developmental trend pathways that kids can take. But I'd say it's case by case, really.
I'm going to separate out ADHD because there is, I'm not going to generalize and say 100% ADHD is not born that way, but there a significant number of children. We know that the diagnosis of ADHD has just skyrocketed, particularly among boys. And in my practice, if I could get parents, even if these were kids, young boys, or boys who were teenagers who were diagnosed with ADHD years prior, and they were maxed out on their stimulant meds, if I could convince the parents and the child, the teen, to cut back and greatly restrict their use of tech, increase their participation in sports, even if it was intramural sports, and if the parent, lots of times the parents needed permission to, hey, you can be authoritative, you can, there needs to be firm rules in the home, firm and loving. You can have these expectations of chores, respect, etc. Even though I was at this point only part-time, the practice would, high success in getting their meds significantly reduced. Their grades would go up, and I would have them come back at like a monthly checkup to cheer on the parents and the student. So there's a significant number of ADHD kids who it's been the screen time, the lack of outdoor play, maybe too much permissiveness that triggered the ADHD symptoms. And so if we can get them away from the tech, the brain is resilient. The neurological system has a lot of resilience, and they can be rewired. So I would say the positive interventions that Dr. Hansen talked about will greatly help kids with ADHD. For sure, if you are just letting them go off on video games and not paying attention to screens, that will worsen the ADHD. The myelination proceeds the same way, so that even on the autism spectrum, their prefrontal cortex that's not going to mature before age 25. So the concept of myelination, that part is the same, but the tech and lack of interaction and play, that can be a causative role in the ADHD.
If I can add one thing. There's a book by Victoria Dunkley, Reset Your Child's Brain, and she speaks really well to differences. She speaks to ADHD kids, depressed kids, autistic kids.
Wonderful, yeah.
And how media impacts them even more. So in some ways, because their brains are already impacted, sadly, these impacts are far worse. But you're right, when you pull
So you're
them
going
back,
to help them when you...
You almost need to be more thoughtful about the
Yes.
impact of media on their brains, because they're already under a certain amount of salt and load. But her book, Reset Your Child's Brain, Victoria Dunkley, is an excellent book. And then again, the other one was Mona Delahooke, Delehoook. She's written a couple of great books on brain development, and then there's another one, Neural Whereabouts, is an excellent book on just helping kids all the way up. It's just a great kind of neuroscience neuropsychological primer to help us get through. It's like, I can't remember, Crystal, I don't remember her last name, but Neuro Whereabouts. It's a phenomenally good book. It should be like almost a Bible. Raising Kids, a really good one.
And I think there are some unifying factors for all children. He talked about the safe place, so kind of a safe, loving, interactive home environment benefits all
Everyone.
children, everyone.
And that's what we're missing so much of.
Yes.
Is that we're not creating, not because we don't care,
I can-
but we're not creating safety, but not safety in a crippling way. Okay, there's a balance between
Right.
letting children have risk, right, but having the home be a safe, connected place.
Right.
And we have these disconnected places the kids come home to, and mom and dad are checked out, not because they're bad, because we're all addicted to these things and we're all stressed. And so we're not able to preach the very things, as that one slide, they have hypocrisy detection devices, because we're not living there. And so any healing for our children starts with us. We have to be walking the talk. We have to be living out this. And I tell my students when I teach them neurofaith, you better be living this before you ever try to do it with a patient.
Any other? Yes, Lee.
Artificial intelligence. What about cartoons growing up? They seem like they're really, really addicted to young kids. They don't want to put the phone in. They don't want to let it go. They don't want to. Is there something in that video, like in the olden days when they had movie theaters, they had pictures, one frame would come up with popcorn. So when we go out and buy popcorn, is there some type of that intelligence going on that you don't see it, but subconsciously you get just
So Lee covered a number of items there.
Yes.
Artificial intelligence, it's kind of a brave new world. We're still just getting our feet wet with it. What is truly going to mean? I mentioned earlier about social media companies using their platforms to addict. I think AI has the potential to worsen that, kind of get smarter at doing that. You know, like anybody trying to sell a product, they're trying to get people hooked on that product. And unfortunately, how do you regulate it? I mean, no easy answer to that. And so, if you want to comment quickly, but that'll have to be the last question.
I'll comment very quickly about AI. I don't know who did the study. I know studies have been done with adults, electrical engineers, and AI. And there absolutely is evidence that even expert electrical engineers lose intelligence after a certain amount of reliance on the AI. So in my opinion, AI it's the worst thing we can be using in schools. Children should not be, exactly. I mean, when grown and mature adults who are experts in their field, and it wasn't just engineers, I mean, I believe they even looked at medicine and other science arenas, when grown adults are losing intelligence, and AI is being implemented in elementary schools, not maybe the idea is to implement it elementary on up, and it's already on the World Wide Web, everywhere, as you said. And kids aren't aware. They think they're learning. They're not learning. We're already tanking. So I recommend homeschooling with books, solid homeschool curriculum. Parents are we are the primary educators of our kids, and we need to take that back for so many reasons. Cartoons. Everything about the phones is addicting and damaging. So from the blue light to what is playing, the subliminal messaging, all the IT developers, they hire psychologists to develop their content and products. So fortunately, there are some companies that make dumb phones. So if for a matter of safety, you want your child to have a phone, go with a quote-unquote dumb phone, which is basically just a real phone. There's no access to the web, no access to social media.
Of course, homeschooling's not the best for everyone. We have some
Right, I'm sorry.
excellent
Yeah,
teachers in the room.
I'm so sorry. Yeah, I
and,
don't want to offend. It's like I'm trying to be really fast.
And so,
Right.
hopefully the information
I'm so sorry, yeah.
that the educators and everyone else here heard tonight
Yeah.
will help fuel their passion to improve the lives of the children in their classrooms. Again, thank you all for coming. And if you have suggestions, there are index cards. Please write out for future topics. Thank you.
Thank you for that.